And there we go. Okay, moving quickly. Disclosures. You can just go to my website. Hopefully, you all signed up for my newsletter. And of course, we have a total societal disaster going on due to junk food, genetics, environmental toxins, a variety of different things that are happening. People sitting in front of their computers, not exercising. And we have to reverse this trend through a number of important tools that we're going to talk about today. And we think right now that there's 100 million people with fatty liver with less than 8,000 hepatology providers, and much less than this is hepatologists, because the gastroheps in our APP community are the ones that are really leading this charge, or should be leading this charge, because there are definitely not enough hepatologists to go around, and we're really focusing on transplant and liver cancer, rare diseases, etc. So this is getting worse and worse, and you can see where the hot spots are for fatty liver. And it's a big hot spot in the Middle East and India. And this has to do again with genetics, lifestyle, carbohydrate, predispositions. But South America, China, and even Africa is catching up, even though we don't have much statistics. Let's talk and see what this bill does. We think it's close to 30% of the adult population have fatty liver in the US. That's why we're coming up with that 100 million value. But not everybody with fatty liver gets cirrhosis or cancer. And if you take a look in general, and I'll reinforce this on a couple of other slides, when you're talking to your patient about fatty liver, they have the diagnosis of fatty liver, you reinforce that the number one cause of death in people with fatty liver is cardiovascular disease. So it's heart failure, myocardial infarction, and stroke. Number two is cancer. That's not listed on this slide other than liver cancer, but there's 13 different types of cancer that are increased in people with fatty liver, especially amplified if they have fatty liver and the different components of metabolic syndrome. So you take 100 million people with fatty liver, 25% of those 25 million have progressive fibrosis. You're down to somewhere between 5 and 7 million who are on that track to cirrhosis and liver failure, because people die from other causes, even if they're having progressive fibrosis. This goes through the numbers and other factors that are involved on that right side. You need to make sure everybody's got normal thyroid tests. You've done a full workup for their diabetes. You've changed their diet. You've stopped alcohol. There is no safe level of alcohol intake. We're not quite yet doing genetic profiling in patients, but I don't think that's too far away. I just sent an email out to Quest and LabCorp, Mayo, and ARUP that they should be setting us up that we can do this risk-based panel to tell who's on a liver trajectory. The data exists, it just hasn't gone into the guidelines yet, but sometimes the guidelines are the last thing to change. On the left side, it's talking about what that timeline is to getting advanced liver disease. And it's typically somewhere between 10 and 30 years. And that timeline, that trajectory is accelerated by things like alcohol. So the first intervention for your patients as you're talking about weight loss, diabetes management, lipid, hypertension, is get them to zero alcohol and document that with PEth testing, which we've talked about before. Of the people with a BMI over 30, up to 90% have fatty liver. Of the type 2 diabetics, up to 70% have fatty liver. So every one of these is an entry point where people need to be screened for fatty liver with liver panel and liver imaging. Standard of care now in the liver community, it's not just an ultrasound, but it's getting elastography and attenuation scores to help stage their disease from the fat perspective, stage their disease from a fibrosis perspective. It's very, very interesting that now malnutrition around the world is a rare event, except in certain war zones such as the Sudan area, East Africa, a few other locations. There are more deaths now from overweight and obesity related complications than malnutrition. Complete shift than when I was an early child growing up. We have a global toxic food environment where people are eating tons of junk food, soft drinks, fructose, sucrose overload. And in the lower socioeconomic communities, they have limited access to healthy food in the terms of what they can get at the corner store, what's available. But you can still make healthy choices. People can still make healthy choices through good education. The current term is MASH, Masld, metabolic dysfunction associated steatotic liver disease. They wanted to get rid of the stigmatizing word fat. But when you're explaining this to patients, you need to tell them they have fat in their liver. They have fatty liver because they're not going to understand all these other terms. And they need to lose weight. You can use the word obesity, overweight, high BMI. There's other tasteful ways to go down this road, but I still use the word fat in there. We now don't use the word alcoholic anymore. That's gone. It's alcohol-induced steatohepatitis, alcohol-associated liver disease, alcohol use disorder. So think about these terms and use current best terminology. And we're tracking major adverse liver outcomes. We're tracking major adverse cardiovascular events, and we're tracking cancer, making sure patients are getting the proper cancer surveillance. This goes back to different criteria. I want you to look down in the little blue boxes there. Blood pressure, 130 over 85, triglycerides over 150, HDL cholesterol less than 40 in men, less than 50 in women. What's missing from this is LDL. You want LDL as a flag for cardiovascular risk in combination with ApoB, Lp(a), and C-reactive protein. I now get that lipid profile focusing on LDL because once I start them on a statin, I'm going to target different LDL targets depending on their overall cardiovascular risk. The reason this is important for GI fellows, gastroheps, APPs, is you need to go back to the primary and tell them to push statins. The statins are not only safe, but they're liver protective. There's still a perception in the primary care community that statins are liver toxic, and you could say, oh yes, 1 in 80,000 people. And in the other 79,999, the statins are liver protective. So give your patients and the primary care the confidence to be aggressive about statin use. This goes back to terminology. We have what's called MET-ALD, metabolic liver disease, overlapping with alcohol-associated liver disease. And that's dependent on their daily alcohol intake, but also because patients are notoriously inaccurate about their alcohol intake. I am going to state that you need to take a good alcohol history. Hey, team, I'm going to put you on hold for 1 second. I have an urgent call I need to answer, but I'll be back in 30 seconds. So take a good look at this slide. Thank you, team. So, my big point on this slide is PEth testing and really take a cage score, take an audit C, uh, you know, just ask in general about alcohol use, but just get a PEth test because it's going to tell you accurately what their alcohol exposure is, what their metabolic status is for alcohol. Now, got to take a good medication history because you have to worry about DILI, SILI, HILI, CHILI, the different forms of drug-induced liver disease. And there are atypical forms of fatty liver disease, one's called lean fatty liver disease that may even be more genetic related. I've talked to your team about genetic testing. And speaking to your team, I'm going to be in Vegas on Monday night. Hopefully, your entire fellow group will be there. That is a talk specifically on genetic forms of cholestatic liver disease. This is a super important meeting for you as a fellow group to attend. We're going to talk about genetic testing, state-of-the-art genetics that drive cholestatic, atypical, unexplained liver disease. Really applies because I'm doing genetic testing in people with lean fatty liver. Super important. I know some of your team have already started ordering that prevention genetics or what's called the Invitae panel. I'll be talking a little bit more about the Invitae panel on Monday night. Is that right? Or no? No, it'll be about the prevention genetics panel. There's two different companies in this space that have two different free panels. So I'll be talking more about prevention genetics on Monday night. So please attend. Let's see, where will that be? That's going to be at the Vintner Grill, 10100 West Charleston. Hopefully you've already gotten that invitation. If not, send me an email. Be glad to repeat that send out. Thank you. Okay, let's keep going here. Checklist: alcohol, other forms of chronic liver disease. If it's cholestatic, rule out PBC, rule out PSC. If you have any questions about that, get an ultrasound. Any suggestions of obstruction, get an MRCP. Hemoglobin A1C, full lipid panel. C-reactive protein, ApoB, LP(a) is part of that cardiovascular workup. Make sure cancer surveillance is up to date, colonoscopy, mammogram, chest CT if indicated, and then take a good family history for cancer. Okay, liver enzymes, very inaccurate in terms of the activity of the liver disease. Healthy ALT for women's under 25, healthy ALT for men is under 30, healthy ALK phos under 115, healthy GGT under 35. Okay, Gordon, you just told me about DDW. You are right. That's going to be interesting. But there's a lot of other people in the community I think we're going to get the word out to. Maybe we want to do a Zoom lecture on that since some of the fellows will be gone. But if you're in town, please come Monday night. Good point. Okay. Hopefully you all will have a device for liver imaging. You don't need to do MRI, PDFF. The CAP score on the FibroScan or the FibroScan equivalent test is very accurate for fatty liver assessment, very useful for following people. I just got this graph about the percentage number of deaths that's increasing from steatotic liver disease. This is a global healthcare crisis that's going on throughout the world. Western Hemisphere is leading the way. Africa is the tail end because they're catching up with our bad behavior. This is prevalence and risk. Prevalence of people who are overweight and the percentage of people who drank alcohol in the last year. This is 2016 data, but there's clearly a spike of activity during COVID, but and that has fallen. It's very interesting in the last 1 to 2 years. Alcohol use, volume, exposure has dropped 20%. People have a lot of different theories, including the use of GLPs is decreasing alcohol use. It's not as fashionable in the people in the 20 to 35 year age range. And We don't fully explain this, but alcohol exposure, alcohol use has declined. So that's going to lead to some improvement in general health and, of course, liver health. So the top line on here is Fib4. So every time you look at a patient with fatty liver disease, you want a full ultrasound, spleen size, portal vein diameter. You're going to look directly at the platelet count. You're going to look at the AST to ALT ratio. You're going to calculate a Fib4. You're going to get elastography. You're going to get an attenuation score, and you can get an ELF test. That's the fourth one down on here. So Fib4, ELF, liver stiffness, CAP score or attenuation score really helps you put together a whole package. What's the stage of their liver disease? Is their trajectory heart disease? Is their trajectory cancer? Or is their trajectory liver disease? Every fatty liver patient, you need to put them into one of those three pods because that helps determine how often you're going to see them. Are you going to use Resdifra? Are you going to use a GLP? You're going to do other interventions to manage their liver disease. So, of course, you're going to make sure they don't have hepatitis C. You're going to cure them of C. You're going to treat their hepatitis B. By the way, there are some new guidelines that came out while I was in Istanbul last week called the Asia Pacific Hepatitis B Guidelines, which I have to say I agree with the most and say AASLD guidelines are the worst. They're basically saying you have Hep B, you just treat everybody. And that's what the China guidelines are saying. And WHO are almost there. So I really want you to be thinking hepatitis B, DNA positive, everybody's on treatment. So that's the data, and that's now in three different guidelines. Don't worry about AASLD, they're out of date. They were very restrictive on what they looked at, what data they looked at. And they do have shared decision making in the AASLD guidelines. So, yeah, you can share the decision with your patient to treat everybody. Autoimmune hepatitis and fatty liver, quite rare. PBC, you know how to work up primary biliary cholangitis. Let's see what's going on. Here we go. Oh, this just has to do with a lot of statistics about screening, but you're going to be already way down the line when this screening takes place. They're going to come see you because you have elevated liver tests. They're going to come see you because they have an abnormal ultrasound or CT or MR scan. It's really back on the primary care side about who should be getting worked up for fatty liver. But we are going well down the pipeline to test everybody for fatty liver who's got obesity, high BMI, metabolic syndrome, diabetes, and then decide who needs to see gastroheps. Natural history. How do you determine where somebody is? How do you look at statistics? This is really for your GI boards. Be thinking about lead time bias, survival time, disease modification, when to do interventions. But from a liver perspective, it's when they hit F2 to F3, you need to be aggressive about interventions, nutrition consults, weight loss programs, stopping alcohol, more aggressive management of diabetes, GLPs, SGLT2s, metformin, hyperlipidemia, really being aggressive. So you need to stage everybody, be accurate. And once they're in that stage 2 to 3 zone, much more aggressive about liver-directed interventions. This just has to do about screening programs. This is something that's quite complex on here. I'm just going to say there's a big shift moving to screening everybody for fatty liver and staging everybody. And let's see, do we biopsy people with fatty liver? Rarely. Only if they have some atypical presentation. We're confused about the staging systems that I've talked about. So in the fatty liver world, I'm biopsying less than 5% of my patients, and I'm doing biopsies because something is very atypical. Like patient today, huge liver, normal liver tests showing a fat attenuation score that was in the 260 to 270 range. Something very atypical about that patient. Now, people with fatty liver and metabolic syndrome have many other things: asthma, depression, anxiety, infertility, gallstones, incontinence, joint disease. So you really need to be looking at that entire patient and really motivating them to lose weight to get many of these different factors under better control. So change in diet, more exercise, aggressive weight loss. People should be losing 2 pounds a week. If they're not losing 2 pounds a week, their calorie intake is far in excess of what they need nutritionally. What's going on psychiatrically, psychologically? You need to be a psychiatrist for your patient. Depression, anxiety, bipolar, panic, PTSD, abuse. There's always a reason why people are making unhealthy choices. And you can get to that through a nice motivational interview, a cognitive behavioral therapy, and you can compress that into a 30-minute appointment by asking key questions and, importantly, listening to the patient. Give your patient time to answer the questions. Cardiovascular risk assessments, really nicely highlighted on here, but the more fibrosis, the higher the risk for cardiovascular disease. What is the trajectory, though? Do they have retinopathy? Is their creatinine 1.7? Do they have peripheral vascular disease? What's their ejection fraction? So there's a way to evaluate your patients and put them into these different domains, these different pods on what is their ultimate pathway towards an early death or just poor health. Are they in a wheelchair? Are they getting bilateral hip and knee replacements? Do they have spinal stenosis? What else is going on to help motivate them to lose weight, to get more healthy? So I tell people that when they lose weight, they're going to sleep better. They're going to have more energy. They're going to have less inflammation. They're going to need less orthopedic interventions, lower risk for cardiovascular disease, advanced cardiovascular disease. So it's really about life extension. Ultimately, you need to take this back to a positive. So there's been a lot of fighting about BMI out there, and the obesity people who think that obesity can be healthy are wrong. There is no such thing as healthy obesity or healthy high BMI. These are people who want to put a spin because they don't want to lose weight. They don't want to pursue these healthy targets. There is no safe level of alcohol. There's been some theories in the past that alcohol might be liver protective or cardiovascular protective. There is no safe alcohol. Alcohol is an entertainment. It's like baseball tickets. They can live without baseball. You can live without alcohol. I want to highlight on this slide the fourth bullet that fructose depletes hepatic ATP and impairs recovery. It is a mitochondrial toxin. So people need to minimize their fructose intake and only be in that fructose world if they're eating fruit, healthy fruit, modest amounts of fruit. We haven't figured out how to modify the microbiome yet, but microbiome modulates insulin resistance. One thing that is clear to me, though, when people are on a vegetarian diet, their biome is very different than if they're on a red meat diet. So personally, I have red meat maximum twice a week. I'm on a chicken, fish, vegetable diet myself. That's how I live, and that's how I advise my patients. It's interesting down the road that we're even going to be measuring fat in the muscle. We'll probably be measuring fat in the muscle with ultrasound eventually, although right now it's MRI and CT. They're calculating this myositis, myopathy, myosteatosis. So keep an eye open for that. That's not that far away. And we're doing lots of point of care ultrasound. That's a big part of gastroenterology, assessing inflammatory bowel disease. But we in the liver world will be doing more point of care ultrasound to assess muscle fat even. Lean fatty liver we talked about before. Lean fatty liver is important from a perspective that these people also are at risk for liver trajectory, heart disease trajectory, and typically, not just cancer too, typically they have increased visceral fat, increased waist circumference. That visceral fat is what's driving a lot of what goes on in the liver and the rest of this cardiovascular metabolic syndrome uh, disease state that we're talking about. So lean fatty liver do the same thing. Stage disease, stage metabolic syndrome, stage lipid profile, get a waist circumference. One of the new vital signs is not just BMI, but waist circumference. This just says that people with fatty liver feel bad. This is an inflammatory disease that makes people have joint aches, muscle aches, decreased energy, chronic fatigue syndrome. CFS constantly moves through different worlds, but this is a specific connection with chronic fatigue syndrome, which is fatty liver. And as people lose weight, the inflammation goes down, they feel better. Give your patient a positive target to be looking at. This visceral adiposity predicts development and progression of liver disease. So people need to be mobilizing that visceral fat. And that's one thing actually that GLPs do a good job. And I don't tell my patients not to take GLPs because I think GLPs are terrible from a general health perspective, but they do help people lose weight. But during that weight loss with GLPs, less than a year, they should be changing their psychology so they get off the GLPs and they keep their weight down by daily weights, daily calorie counts, doing other things to modify their hunger drive. In America, we're entitled. We're entitled to all sorts of things, but we're entitled to eat endlessly and never gain weight, or eat endlessly and lose weight, but those are not consistent. GGT should be part of every liver panel for every patient with any type of liver disease or suspected liver disease. GGT is a surrogate for cardiovascular outcomes and liver outcomes. You should be ordering a GGT and direct bilirubin in every liver panel for the rest of your career. This is new news. There's a lot of adult senior hepatologists that don't use the GGT. Very weird, in my opinion. I think some people just get stubborn in their ways and also say, well, I'm not going to think unless it's in the guidelines. That's called guideline paralysis. You have the ability to think outside guidelines and look at all this evidence. Look at how many GGT data points are out there as a predictor of type 2 diabetes, developing type 2, having ongoing active cardiovascular disease. NAFLD risk for overall mortality, higher the GGT, higher the mortality rate in fatty liver versus general population. GGT is your friend. So we talked about the simple 7, platelet count, AST to ALT ratio, spleen size, portal vein diameter, Fib4. You could also consider APRI or NAFLD. Right now, I'm putting ELF up into the simple 7 and not using APRI. I do consider the NAFLD score that's here, definitely plugging in elastography, definitely plugging in an attenuation score. Simple 7. Most of this is free or low cost. ELF is your friend. Procollagen 3, amino terminal peptide, and hyaluronic acid. And hidden behind here is this TIMP protein. But anyway, you get 3 markers of collagen turnover, collagen development, fibrosis development. And the ELF score, 7, 8, 8, 9, 9, 11, gives you those stages of liver disease up into cirrhosis. ELF is available through all the different labs. I haven't had a problem getting it paid for. There's a lot of competition out there in the fibroscan world. That's on the left side, but in that world, there's a test called High Sky. There's something on the right called ARFI, which supposedly UMC is supposed to have one of these devices on site, but it's unclear where that status is. And Velicure is something that has this method of establishing KPA through another vibration controlled test. So there's lots of ways to measure liver stiffness. All of these devices have an attenuation score. The attenuation score tells you how much fat. The stiffness, depending on what technology you use, tells you how much fibrosis. VCTE is what was developed first and early. This is the FibroScan, and you can get up to 14. Once you're over 14, it's very likely that person has cirrhosis, and you're going to look at that in combination with their platelet count, right? That's called the Baveno criteria, and you need to know Baveno criteria. CAP score, healthy is 220, severe fatty liver is 330. And this CAP 275 is right in that middle zone. Healthy 220, severe 330, and you have stepwise from 220 to 330, building up different levels of fat severity. There's a test not available in Las Vegas called a corrected T1. This is a way to look at fibrosis and inflammation together. About, I'm going to say, 2/3 of the score is inflammation, 1/3 is fibrosis. It's a great way to track inflammation in the liver without a biopsy, and useful not just in fatty liver, but in conditions such as autoimmune disease. But this is FDA approved, but CMS only pays for it in different parts of the country. I don't know what the company did, but they just never got this technology accepted throughout the US. And there's only a few places in California where you can get this done. I like it. So, imaging, there's a number of other tools on here. I'm not going to go into these. These are tools that we really don't use, although the FAST test in the upper left corner is a data output if you have a FibroScan machine. All right, so screening for fibrosis, type 2 diabetes, yes. Medically complicated obesity, yes. Fatty liver detected on any type of imaging, yes. You want to stage all of these patients. Liver stiffness predicts outcome. 10 kPa on FibroScan, much higher risk of cancer, much higher risk of liver failure. So this kPa predicts the future. There's one other test that's available in Las Vegas, which I can send you all the link for, something called HepQuant. I don't think that's in this slide deck. But once you determine that somebody has cirrhosis, but you don't know where they're going, how much liver reserve they have, how much liver function they have, how much shunting they have, there is an LDT, a laboratory developed test called HepQuant that can really help stage your early cirrhosis patients. We'll talk about that during another lecture. This is genetics. This is what we're going to talk about in Las Vegas next Monday night. What's up in that little red box? There's over 143 genes that are associated with cholestatic liver disease. In the lower right-hand box, the blue box is what I'm trying to get Quest and LabCorp and other labs to give us, because those are the genes in fatty liver that predict severe outcome, aggressive liver disease. Okay, we discussed everything on here. These are algorithms for primary care, when to refer people to gastro. Over 1.5 is some fibrosis, 1.3, sorry. Over 2.67, they need to see a gastro hep. Those people have advanced liver disease. So Fib4 is a nice screening test. It has a great negative predictive value. It's really for primary care to be using Fib4 as an initial intake screening test and then combining it with ELF because no single test is perfect. It's always nice to have two, best to have seven, but they're trying to make this simple for primary care on when to refer and when to keep inside their practice. All right, I'm going to skip over that. When people lose weight, all these things get better. My point on this slide is to target a BMI of 24 for Caucasian, Black, and Hispanic, 22 for Asian, including Indian subcontinent, that Asian subcontinent area. People from India, Bangladesh, Pakistan, Afghanistan are very sensitive to slight increases in weight from a genetic basis. They should be, that group, Asia group, should be targeting a BMI of 22 and normal waist circumference. There's lots of fads out there. I call them fads because you could have fasting, 5-2 fasting. There's the paleo diet, the caveman diet, these different diets. But the bottom line is it's about losing weight and decreasing people's appetite drive. Because when people are hungry in America, they're entitled to eat and they should be able to eat and lose weight. Well, that's wrong, of course, but that's the American entitlement. Watching all these shows that are on TV, all the different media, social media feedback loops is part of our disease state. So definitely with pharmacologic therapy, we can accelerate weight loss. There's some drugs I don't use, such as bupropion, naltrexone, or phentermine. I do try to get people to manipulate their microbiome by a vegetable-based diet. I'm rarely sending people for bariatric surgery. It's once their BMI is over 40 and they've failed, supposedly failed. But remember, once they get a BMI over 40, it's incredibly difficult to exercise. And it's very difficult for a person to get to a calorie count of 800 to 1,000 calories a day because they're hungry all the time and they don't feel good. So they keep eating. But definitely pharmacologic therapy. But when I have a patient taking a GLP or they're thinking about GLP, I already put them through an aggressive informed consent because GLPs damage muscle. They cause muscle wasting, bowel obstruction, pancreatitis, rare forms of cancer. There's a lot of things that GLPs are doing to our bodies that are not healthy. So it should be for short-term use. Bariatric surgery works. These are just a whole bunch of references you can look at. How much weight loss does it take to really improve people? 30 to 40% to resolve fibrosis. But in the mix here, we have medications. We know that GLPs reverse liver disease. We know that resmetirom reverses liver disease. And the data for resmetirom by biopsies, 1 out of 3 people at 1 year. But if you look at imaging, it's 2 out of 3 people benefit from resmetirom therapy. And that imaging data is in the package insert. This is definitely duodenal mucosal resurfacing, where you just fry the duodenal mucosa to cause malabsorption. That never went anywhere. Endoscopic procedures, yes, there are some places in the country that do these, but there's really a small set of people who have that skill set to do that procedure well. Gastric balloons, they're in style for 3 years, they're out for 7 years, they come back in style for 3 years. But this endoscopic sleeve gastroplasty is one of the most popular ones right now, which I think I have the most support for. Liraglutide failure. Semaglutide's coming out with an oral version, so it's not injectable at high dose, may have less side effects, Monjuro is definitely better for weight loss and I think has less side effects. And there's a lot of other drugs that are coming out there, including FGF21 and some different PPARs, including what's called lanifibranor. So we're going to wait and see where those hit the market after FDA approval. I do think they will be FDA approved. So GLP upper left corner for semaglutide for MASH, tirzepatide also looking good in the right upper part of this graph. Um, Lower less survodutide is coming. That's a GLP glucagon receptor agonist. So GIP, GLP-GIP upper, GLP-GIP lower left, and retatrutide, which is a triple agonist, is also in development. This has to do with adverse liver outcomes. So GLPs, even in people with cirrhosis, do better on GLPs. So not only are they safe in cirrhosis, but better outcomes. But this again should be, in my opinion, short-term use, not 5, not 6, not 7 years of use, unless there's another indication such as diabetes. All right, so what's happening here? I mentioned lanifibranor is coming, efruxifermin left is coming, Madrigal, resmetiron's already on the market. Seladelpar didn't make it for complicated reasons, but it's being used for PBC and has a fatty liver benefit. It's not in the package insert, but it's published data. We mentioned semaglutides coming even in the form of an oral. Intercept Ocaliva drug was killed because of liver risk benefit ratio that the FDA didn't like, the company didn't like. All right, let's see. Reducing liver fat on treatment. This is a new slide, and this just has to do with different pharmacologic therapies, which is called a systematic review and what's called a network meta-analysis. So you have to look into the fine print, but all the different drugs out there, and superior to placebo is in green. The upper one is absolute reduction in liver fat, and the lower set of circles is greater than a 30% reduction in liver fat. So what's important on here? Semaglutide's definitely in that favorable green group. So that's it's available. And there's a number of new drugs that are coming. What I don't see on this, because I just got this slide a couple of days ago, is resmetirom is not on the lower one and not in the upper one either. So that's kind of interesting that resmetirom's not on here, but a lot of new drugs coming. This is resmetirom showing resmetirom versus placebo in terms of 1 stage or greater fibrosis improvement. So resmetirom is really your friend out there for people who don't want GLPs, have failed GLPs, side effects from GLPs, can't pay for GLPs. There's a huge role for resmetirom out there in managing fatty liver, and it does reverse liver fat and liver fibrosis in up to 2/3 of people. All right, so resmetirom here, reversing liver stiffness on FibroScan, that's on the left side, and changes in VCTE on FibroScan. Here's just look at the 100 milligrams, about a 50% had improvement in KPA. Reduces liver enzymes. But if you look at liver enzymes at 4 weeks, resmetirom causes a spike in AST and ALT. But here, ALT, AST, and my favorite liver enzymes, GGT, out to week 48. And I believe this parallels what you see on liver imaging. ProC3, not commercially available, but this is a marker of fibrosis, improvement here. And MRI-PDFF, and I think the MRI-PDFF data was at 4 months, showing a marked reduction with resmetirom. CAP, Look at this. I think the cap data here is at 6 months. And then liver volume, as liver fat decreases, liver volume goes down and spleen volume even improves. So resmetirom is a great drug. This is oral, it's liver targeting, it doesn't cause weight loss, it doesn't treat diabetes like the GLPs do. This is really a good drug for people who are, say, losing weight, their diabetes is getting better, but their liver fat score is staying the same. They're a fibrosis 3, and you want to intervene to reverse that liver fibrosis. Resmetirom is your friend. This is a little bit of a complicated slide because I think we're getting close to the end here. Just more data on resmetirom's benefits. Really nice information on this about resmetirom. Look at the right group of graphs. It's the only drug I've ever seen that reduces LPA. LPA is supposedly genetically programmed and you can't reduce LPA, but here is a drug that reduces LPA, an incredible driver of cardiovascular risk, reduces ApoB, reduces LDL, reduces triglycerides. So resmetirom is your friend, but it has an interaction with statins. You want to keep statins at 20 milligrams to keep it simple to minimize drug-drug interactions and reduce risk of statins for muscle toxicity. It's not liver tox, it's muscle toxicity. All right, so F2, F3, intervene. We don't have data with resmetirom that's been published in the cirrhosis group yet to say it's time to use it in cirrhosis. There is some data that's emerging, but right now we can sit tight and wait in cirrhosis with resmetirom. All right, just how to follow people. Bottom line is every 6 to 12 months, you repeat liver imaging, liver enzymes, platelet count, FIB4, and decide if you're going to continue resmetirom. Resmetirom does cause some GI toxicity, some nausea and diarrhea, typically in the first 2 to 6 weeks, but people get over it. They get tachyphylaxis, gets better. So resmetirom is your friend. All right, just to wrap things up, look at all the things going on. Treating fatty liver, metabolic syndrome. There's a bunch of drugs in here that have failed. They have little red X marks next to them. This is a beautiful slide that must have taken somebody a month to put together. But there is work going on to bring better drugs forward. But ultimately, people need to change their behavior long term. That will help them immensely. Let's see, is there anything else out there? I've discussed all of this. There's other slides. I sent the link on these slides to Vig. Hopefully he's available and he can forward that on to you, or I can send it to one of your other team members. I don't know, tell me who you want me to send it to. Ultimately, this care model, primary care, endocrine, gastro-hep, nutrition, lifestyle, psychology, cardiology. You need to motivate your patients to change their behavior. And let's go to Q&A in our last few minutes. Good to see so many people on this. Hopefully you all have a good DDW. But if you're not a DDW, I expect to see you Monday night.
I had a question, Dr. Gish. Thank you for the presentation. So, in the recent ACCH guidelines on lipids, they specifically talked about LDL cutoffs for like ACVD or CKD, diabetes, so on and so forth. But it didn't quite touch upon cutoffs for LDL, specifically for MAFLD or MASH. Are there any like ASLD guidelines or any recommendations on that?
I'll make it simple. High LPA over 70, you need to target an LDL less than 70. If the LPA is over 150, LDL target is 50, 50. So just remember 70 and 50, or 150. ApoB helps you adjust that. If you've got somebody in a gray zone with LPA and the ApoB is over 130, they need to be aggressively managed. C-reactive protein, 9 or 10. Those people are very high risk of cardiovascular disease. Get that LDL down to less than 70, maybe down to 50. So look at that combination, LPA, ApoB, CRP. The higher each of those numbers in combination, the more aggressive that LDL needs to be. And you all shouldn't be managing LDL in your practice. You need to just talk about this algorithm, these tests, and tell the primary care to be aggressive. People are terribly under-managed, under-treated with statins. I don't know why. Lazy primary care providers, not enough endocrine. Cardiologists are busy doing caths and stents. I don't know where everybody is, but you can reassure people they need to be aggressive with statins, LDL reduction. It's liver protective, cardiovascular protective, and probably cancer protective. Sound good?
Yep. Thank you.
Good to chat with everybody. Talk to you soon. Have a great DDW.
Thank you.
Bye.